Welcome to this renal cell carcinoma tumor board sponsored by Pfizer and the NCCN through Duke University. My name is Tian Zhang. I'm one of the GU medical oncologists.
Hi, I'm Lisa Ho. I'm a radiologist.
Hi, I'm Wen-Chi Fu, and I'm a pathologist.
Hi, I'm Mike Harrison. I'm a GU medical oncologist.
And I'm Brant Inman, and I'm a urologist.
So we'll start with our first case today. This is a 50-year-old, previously healthy man who initially presented with right flank and rib pain associated with movement. Physical exam revealed normal vital signs, a Karnofsky performance status of 100, and he was a well-appearing man and no acute distress. And otherwise, the physical exam was benign. His labs were significant for a hemoglobin of 12.5, but a normal hematocrit of 39, white blood cell count of 8.7 with neutrophils of 6.2. His platelet count was 212,000. His calcium was high at 12, and his creatinine was normal at 1.2. LDH was normal at 108. This ultimately led to an imaging study. Dr. Ho will discuss our initial imaging for this patient.
The imaging that he first received was an enhanced MRI of the abdomen, and this image shows that there is a large mass in the lower pole of the right kidney, and it looks to invade the renal hilum, but the renal vein was not involved. In addition, he had metastases involving the right lower ribs, and the arrow is pointing to a large soft tissue component to this right 11th rib metastasis.
So that brings us to the first discussion point of this case, and that is the necessity of biopsy. And for that, we will turn to Dr. Inman.
Well, when I look at these images, it's more likely to me to be a renal mass metastasized to the bone than a bone lesion metastasized to the kidney. So in this case, the presumptive diagnosis is one of kidney cancer. The question of whether or not you need a biopsy depends on what you're going to do next. If the patient is going to be a candidate for a nephrectomy, then I wouldn't do a biopsy because the biopsy is not going to change what I do. On the other hand, if it's a patient who's not going to go to nephrectomy, then I would consider a biopsy because we need a tissue diagnosis to decide on how best to manage the patient next. So in this particular patient, because I think he would potentially be a candidate for nephrectomy, I probably would not be considering a biopsy.
Great. In terms of prognostic categories, Dr. Harrison will now discuss the Memorial Sloan Kettering Cancer Center criteria as well as the Heng criteria.
Sure. So this is summarized on this slide. There are several prognostic criteria that are used. The first one that's probably the most widely used is the Memorial Sloan Kettering criteria. It consists of 5 criteria. This was published in 1999 by Dr. Motzer et al., and the reference is at the bottom of the slide there. But again, it takes into account 5 clinical factors. So having a low Karnofsky performance status is a risk factor, as is having a high LDH, a low hemoglobin, a high corrected calcium, and having had no prior nephrectomy. All of these are risk factors. Then based upon the number of risk factors, you can group the patients into prognostic categories. So if a patient has 0 risk factors, that corresponds to a favorable risk category. 1 to 2 intermediate risk, and 3 or greater is a poor risk. And these correspond to different survivals. Now that's been updated. The initial Memorial Sloan Kettering criteria were published in the cytokine era. Now that we're firmly in the TKI era where we're using drugs like sunitinib, these criteria have been updated. And the first 4 were retained. So what was added was a short time to diagnosis to therapy of less than 1 year. Thrombophilia was added, neutrophilia was added, and I'm sorry, LDH was actually omitted, the second prognostic factor, because it is not routinely checked. So to summarize, what's called the Heng criteria has 6 risk factors. And again, you can group those patients into risk categories. A patient with favorable risk, as is shown on the slide, has a prognosis of about 3 to 4 years. Our patient has 2 risk factors, so that patient would be expected to have a median survival of about 27 months, whereas poor risk patients have a survival of about 9 months. So in summary, I would say, looking at this patient, he would appear to have a good enough prognosis to think about things like cytoreductive nephrectomy and other local therapies.
That leads us to our second discussion point, which is what is the role of cytoreductive nephrectomy in this case?
Okay, so cytoreductive nephrectomy is when we remove the kidney in the presence of metastatic disease and when we have not removed all of the cancer because presumably there's metastases somewhere else that we haven't removed. And there's two main reasons we might consider cytoreductive nephrectomy. The first is symptoms. So a symptomatic kidney tumor that's bleeding or painful, even if they're a poor risk patient from a cancer standpoint, might be a good candidate for nephrectomy to improve their quality of life for whatever time they have left. And the second reason we might consider it would be to improve their survival. And there's two large randomized trials in the cytokine era that have been conducted. One was a SWOG trial, and the other one was done by the EORTC. And those trials were pooled in a large analysis, and it showed that there was a benefit to doing cytoreductive nephrectomy in combination at that time with interferon versus interferon alone, and it improved survival by about 6 months. We don't have any trials that have been published in the current TKI era, although there are two that have enrolled, the Carmina trial and the Surtime trial, and those are expected to produce results in the next couple years. But we expect to see probably a similar benefit, although it's really not known. So for me in this patient, the best current data that we have suggests that patients who have their kidneys removed, even in the presence of metastatic disease, live longer and have less local symptoms. And the complication rate of cytoreductive nephrectomy is pretty low. About 25% of patients will have a complication, but of those, really only 5% are grade 3 or higher. Grade 3 or higher are complications you actually need to do something about. So the majority are minor complications. So because there's very few complications, and because there's a potential survival benefit, and because there's a symptomatic benefit, in general, if the patient's in good condition and can tolerate the surgery reasonably well, we would recommend cytoreductive nephrectomy.
Great. So this patient initially underwent a right adrenal sparing nephrectomy and right 10th, 11th, and 12th rib resection. We have the pathology of his initial resection, and Dr. Fu will talk us through that.
So the image that's shown here is from his nephrectomy specimen, and basically everything that you're seeing is tumor. So the tumor morphology of his particular cancer is actually pretty classic. So the cells have abundant, very clear cytoplasm. The nuclei are fairly round, but they're pretty enlarged, and the nucleoli are very prominent. The vasculature is relatively delicate, and there is a fair amount of it. All of this is really good for a diagnosis of clear cell renal cell carcinoma, and this looks fairly high grade in appearance. The majority of the tumor was graded as a Furman grade 3. The next slide shows a higher magnification of some of the more focal areas of the tumor that had very large, very prominent pleomorphic nuclei that have some nucleoli that are actually the same size of the red blood cells that are on the slide as well, and that would be more consistent with the bizarre atypia that you see with a Furman grade 4 case. So he had a very high grade clear cell renal cell carcinoma. Along with the nephrectomy came his chest wall resection, and along with the ribs there was a large soft tissue tumor mass, and this is a representative section from that. If you take a look at the morphology of the tumor cells here, you can see that they look very similar to the initial image that I was showing of his kidney tumor. So morphologically this is consistent with a metastasis from his clear cell renal cell carcinoma.
Thank you. Subsequently, the patient underwent a bone scan, and Dr. Ho will talk to us about that bone scan.
These are frontal and posterior images on the left from his bone scan, and you can see when the arrow is pointing to various sites, one in his right calvarium, his left clavicle, and his left tibia are all sites of abnormal metabolic activity there, indicating that they're most likely to be metastases. The next image is a cone down view of his scalp, his calvarial region, again showing high activity in his right calvarium, consistent with metastatic disease.
So at this point, we considered local therapies for the patient, including metastasectomy as well as external beam radiation. And I'll have Dr. Harrison talk a little bit about which to choose for this patient.
Okay. And, I think the thing to recognize is that, it doesn't have to be one or the other. It could be both. Dr. Inman can maybe talk a little bit about this as well. Metastasectomy is appropriate when there are one or maybe a few lesions that we think we can remove, again, to debulk either all of the tumor or the vast majority of the tumor. Certainly, external beam radiation therapy is appropriate when a lesion can't be removed, for example, in the skull, not practical. So certainly this is a multidisciplinary discussion amongst usually surgery, urology, that is, medical oncology, and potentially radiation oncology. I'll just add that several, retrospective series looking at metastasectomy have shown that patients can have good outcomes. I don't know if you have anything to add there, Brent.
Yeah. Well, I would comment that at the outset, this patient had a metastasectomy in his ribs. So, and the reason that was done was predominantly for symptoms, but also because at the time of initial treatment, it was the only known site of disease. And at this point, 3 months later, we now know that he has more extensive bony disease than we had previously. I think at this point, one of his metastases is in the clavicle, and it is quite symptomatic. So one reason for doing a metastasectomy other than for potential cure would be for symptom control, because it can be very effective for that. And particularly in the clavicle, where it's prone to break, this is an area where we would consider bony resection. The data on metastasectomy for kidney cancer are actually pretty interesting. For patients who have lung-only metastases and that are completely resected, their 5-year survival is almost 50%. For those patients who have disease in the bones, liver, or lymph nodes that are completely resected, it's not quite as good. It's maybe around 30 to 40%, but it's still a lot better than virtually any other treatment at 5 years for metastatic cancer. So for me, if a patient is in good shape, has a good performance status, and that's key, has a limited number of metastases that we feel we can completely resect, then they're generally, and with minimal morbidity, I must say, because if you have to remove, for example, an entire leg, the morbidity of that would be probably outweigh the benefit. So it has to be a procedure that has reasonable morbidity. Then there's a potential benefit to the patient, not only in terms of quality of life, but quantity of life. For those patients in whom we can't have a potential cure, then we really only consider it as a palliative maneuver, and prefer radiation if it's possible. For example, for axial spine metastases, where there's multiple metastases, would prefer radiation in that setting.
Great, thank you. Continuing on with our case, the patient underwent a left medial clavicle wide excision with pathology shown here.
So this is a representative image from his clavicle resection, and the bright pink material that you're seeing sort of in the upper right-hand corner of the screen represents bone. So normal bone marrow is actually hypocellular. You should see hematopoietic elements and fat. And what you're seeing here in the majority of the screen is actually a very hypercellular infiltrate of epithelial cells. And if you sort of think back to the original morphology of his tumor, you can see that they look very similar. So this is consistent morphologically with a metastasis from his known renal cell carcinoma.
Thank you. So 4 months later, the patient underwent a CT of his brain, and he also underwent radiation to his skull to 30 gray in 10 fractions. After he underwent local therapy, he had a CT chest, abdomen, and pelvis 5 months after his initial presentation.
The image on the left shows lung bases. There is a nodule in the right lower lobe, and the image on your right is a soft tissue window image of his pelvis showing a soft tissue mass originating from his left acetabular, also consistent with metastasis.
So at this point, we come to a role for systemic therapies for the patient, and Dr. Harrison, if you would discuss choosing his first-line systemic therapy at this point.
Sure. So now the patient has had fairly aggressive surgical debulking. The patient has had radiation therapy, and what systemic therapy do we choose? And certainly based on the patient's risk factors, based on the patient's age, we did think about high-dose IL-2. High-dose IL-2, though, has a response rate in the neighborhood of about 15%. So maybe 7% complete responses, only half of which are durable, maybe 8% partial responses. So when we were thinking about how to treat this patient, we were thinking mainly of that lesion in his pelvis and thinking of the size of it, and that if that continued to grow unchecked, he may start to have symptoms. So we needed something with a little bit higher response. And so for that reason, we actually chose sunitinib. Certainly either sunitinib or pazopanib are first-line therapy choices in this setting. So a patient with clear cell metastatic renal cell carcinoma, good or intermediate risk. The difference, again, between drugs like pazopanib and sunitinib and high-dose IL-2 are that the response rate is probably in the neighborhood of 30 to 40%. Now, they don't have the same chance of a long-term response basically if you just compare complete responses. So complete responses are probably maybe 1% or non-existent with drugs like sunitinib. So we did talk about this and counsel the patient very extensively about that and elected to go with the agent with a higher chance of response. We also talked to the patient about anti-resorptive agents. So there are two drugs, zoledronic acid, which is a bisphosphonate, or denosumab, a rank ligand inhibitor, which are reasonable to use in patients with skeletal metastases with renal cell carcinoma. If you look at the trial, which was in all solid tumors, it was a phase 3 trial. Actually, either one, they both included a significant proportion of patients with metastatic renal cell carcinoma, and either one of these drugs did appear to delay or prevent skeletal-related events. So I would say using a drug like either zoledronic acid or denosumab with the systemic therapy is important in this setting.
Do you think there's a role for any of these anti-reabsorption agents? Do they have an anti-neoplastic effect?
That's a good question. That's been investigated, fairly extensively in different randomized phase 3 studies. It's not clear in renal cell carcinoma, at least clinically, that they do have an anti-neoplastic effect. But I would say they do add to the systemic therapy in terms of preventing important morbidity from the cancer. So they're very important in that regard.
Very good, thank you. That wraps up our first case, and we'll move on to our second case. So this was a 65-year-old woman who had an ankle injury which prompted an orthopedic referral, and subsequently she developed lower back pain for about 6 weeks, and an MRI of her spine revealed both a bulging disc as well as incidentally found a large left renal mass. So she was referred to urology, and a CT of her chest, abdomen, and pelvis was obtained.
So the image on your left shows an enhanced CT, an axial image through the upper abdomen, and there is a large enhancing mass coming off the upper pole of the left kidney. There's some central necrosis and clearly concerning for a tumor. In the right image, this is the lower right lung, showing a nodule in the right lung concerning for metastatic disease.
Great. On exam, her vital signs were all normal. She had a good performance status with ECOG performance status of 0. Her physical exam was benign, and her labs, her comprehensive metabolic panel was remarkable for a normal creatinine of 0.7, a high calcium level of 10.7, and an albumin of 5.2. A complete blood count with differential was remarkable for a platelet count of 484,000. She did not have any neutrophilia, and her LDH level was normal. That brings us to our discussion points for this case, and for this we'll start off with her prognostic criteria as based on the Hang criteria.
Okay. So if you remember back to the previous slide, the patient had 2 risk factors, which was a barely elevated corrected calcium and also high platelets. So this would put the patient in the intermediate risk category. I think, one thing to realize about Heng criteria, though, it doesn't necessarily consider some other prognostic factors. So, for example, things that would point towards a patient maybe having a kind of a better than median overall survival would be things about having, as far as we know at this point, only one site of metastasis, which is in the lung, having a good performance status, and having a normal LVH. So, I think one thing to realize within the intermediate risk criteria, it can be a little bit heterogeneous, but I would say this patient is probably toward the favorable side of that even.
Dr. Inman, can you comment on the role of cytoreductive nephrectomy for her?
Yeah. So as I mentioned, there's two main reasons we do cytoreductive nephrectomy. One, for symptoms, bleeding, pain from the kidney, and two, potentially to prolong life. And that data is coming for the prolongation of life mainly from the cytokine era, and that there's 2 new trials in the current era that have yet to be reported. Another thing that I wanted to mention about cytoreductive nephrectomy is when we're considering a patient to do cytoreductive nephrectomy, one of the things we look at is the total tumor burden. If in removing the kidney we can remove at least 75%, and probably best if it's over 90% of the tumor burden, there appears, at least in retrospective studies, to be better outcomes than if we're unable to do so. So if someone has really high volume metastatic disease, I wonder if the role of cytoreductive nephrectomy in that patient is important. In this particular patient, we have a limited number of lung-only disease sites. Based on the imaging that we're shown, it's not clear to me if the lung lesions are removable or not, but the first question I'd be wondering is if they are. If the lung lesions are removable, we would consider either removing the lung lesions first, followed by cytoreductive nephrectomy, or cytoreductive nephrectomy followed by removal of the lung lesions as her best chance at cure. If they're not removable, if the lung lesions are not removable, then cytoreductive nephrectomy would be appropriate. And at our place, we consider several different options. If the tumor is really large or invading into adjacent organs, then an open nephrectomy is usually required, particularly if there's venous involvement with thromboembolism possibilities when you're manipulating a tumor thrombus. But if the tumor is not invading adjacent organs, even if it's big, we can consider a laparoscopic approach, which minimizes the morbidity of the surgery. And most patients after a laparoscopic nephrectomy, even for a large tumor, will go home in 2 to 3 days with minimal chance of complications. So in this patient, looking at the imaging that we have, it's a large tumor. I think a laparoscopic or open radical nephrectomy would be appropriate. And like I said, I would consider metastasectomy after reviewing all the images. And even if it's bilateral lung lesions, if you can remove all of the lung lesions, then it might be worthwhile considering that as a attempted cure.
Great. And then in terms of systemic therapies, though, for her, Dr. Harrison, can you discuss whether she would be a candidate for IL-2?
Sure. Well, first of all, I'll say I completely agree with Dr. Inman. We should certainly consider metastasectomy in this patient of the lung lesions. We would definitely have a multidisciplinary consultation, for example, with a thoracic surgeon. And so I'll discuss first-line therapy in the case that the patient were not eligible for several metastasectomies. So I think this patient stands in distinction to the prior patient. They are technically similar risk. They're both intermediate risk, but I think the main thing with this patient is that the patient has lung-only disease, and if the patient's lung disease were to grow considerably over 3 months, for example, we usually would not be worried that the patient would become symptomatic in that time. So for that reason, I would favor high-dose IL-2 in this patient, assuming that otherwise, in terms of comorbidities and goals of care, she's a good candidate. I would consider high-dose IL-2, again, because it is the only therapy that has a chance of complete response, albeit small, again, about 7%, half of which are durable. Certainly a first-line VEGF inhibitor would also be reasonable. There is level 1 evidence for that, so either pazopanib or sunitinib in this patient would seem reasonable, but you are in a sense foregoing a chance of a complete remission because those drugs, as I mentioned previously, are not known to induce complete remissions.
Can I one question about the high-dose IL-2?
Sure.
I think you're right that the overall response rate is only about 15%, and really Half of those are complete responders, and half of the complete responders are durable.
Right.
But if we look at those subjects that have had a complete response and was durable, it tends to be patients just like these ones, this one with lung-only disease, whereas patients who have liver or bony disease tend to respond less to high-dose IL-2. So this patient has actually, even though she has intermediate risk disease, her prognostic factors for a good response to IL-2 are in favor of that treatment. And the second question I guess I would have is, if the patient chooses high-dose IL-2, how long are we delaying VEGF therapy for this patient, presuming they don't respond or they progress?
Yeah, so that's a good question. So, I mean, on your first point, I think you're spot on, and this is where, you know, again, maybe the prognostic criteria are less useful because this patient does have such a good performance status, having lung-only disease. The patient appears to be more likely to respond, and they've done trials where they tried to select patients and shown that potentially, you know, they would have a higher chance of response than what I quoted. So I think that's a fair point. And what was the second question?
The second had to do, if you choose high-dose IL-2 and it doesn't work, how much time have you lost before you start the VEGF
Oh,
therapy?
that's a good question. So, you know, typically high-dose IL-2 is given in the hospital in an intensive care unit-like setting. It's given up to 14 doses in a cycle, so maybe over about 4 to 5 days. If the patient did well, the patient would get another cycle several weeks later, and then the patient would get imaging approximately 2 to 3 months after starting. So at the most, you might lose about 3 months with high-dose IL-2 in terms of potentially delaying VEGF inhibitor therapy. So, you know, typically, again, you're going to want to select patients with a relatively low burden of disease and in whom, if their cancer progresses, it's not likely to cause them symptoms in that time. So that's a good point.
So this patient elected for cytoreductive nephrectomy, followed by high-dose IL-2. Her stress echo showed a left ventricular ejection fraction of 40%, and a cardiac MRI showed confirmed the left ventricular ejection fraction of 50% with some left bundle branch block, but otherwise no stress perfusion deficits, and other organ functions were within normal limits. So she underwent 2 cycles of high-dose IL-2 with chest imaging before and after, if you would comment for us.
So we can see that the nodule in the right lower lobe has markedly decreased in size on the follow-up on the image on the right.
Great, thanks. And that concludes case number 2. Thank you for joining us for this renal cell carcinoma tumor board.